start momentarily. Thank you so much for joining us today. Hello and welcome to Pave Your Path episode number 2, How to Use the Model for Improvement. We're so pleased that you've joined us for today's webinar to learn more about the quality improvement process from experts at the Institute for Healthcare Improvement. Our objectives for today's webinar will be to describe how to use the 3 questions for the model for improvement. We will also describe a PDSA for you and describe how to learn from PDSAs as well. If you have any questions during the duration of today's presentation, please email them to hhqi@wvmi.org, and we'll get to as many as we can during today's live presentation. In looking at the agenda, we will first start with a welcome and overview, which we're doing right now. Then we'll hear from our keynote presenters on using the model for improvement and iterative learning, PDSA. We'll find out what it all looks like, and we'll look at next steps. I'll pause for a moment now to see if Cynthia Pammon is available to deliver opening remarks. Moving forward, we'll talk with our keynote presenters next, starting with Corey Seven, who's a director with the Institute for Healthcare Improvement. Corey has led work in redesigning the clinical office practice, improving transitions into home health care, emergency department flow, improving transitions in care to reduce readmissions and spread. Corey is a nurse practitioner with a clinical specialty in adolescent, preventive, and community health. We'll also hear from Jane Taylor, who's an improvement advisor with IHI. She's a healthcare research practitioner with more than 20 years healthcare experience. Her leadership roles also include working as a hospital CEO in rural areas and as a compliance officer for physician practices. And Sally Sobolewski is a director of practice improvement at the Visiting Nurse Service of New York, where she works with leaders and frontline clinicians in designing, testing, and implementing ideas and practices to achieve, exceed, and sustain quality measures and improve patient care and safety. I'm pleased to pass today's presentation to our keynote presenter, Corey Seven. Corey?
Thanks, Shannon, and happy to be here with you today. All right, Bethany, if you don't mind giving me the ball. Oh, thank you very much. There we go. So hello, everyone. Glad to be here with you today and get us started. We wanted to follow up on this, our second call, with the homework that we assigned on our first call, and what we asked folks to do is to post some aim statements. If you remember last call, we talked about the importance of setup and leadership tasks for improvement work, and the other thing we focused on is what makes a good aim statement, which is really your north and guiding star for your improvement work. And so we wanted to bring some examples of the aim statements that were posted. There were many really great aim statements posted. So let me just highlight a few things. You're probably reading these already. Highlight a few things in here. First, one of the key things in an aim statement is what you want to do. So in this top aim statement, this group wants to decrease their acute care rehospitalizations for patients with congestive heart failure by 40%. So that describes not only what they want to do, but also their goal, which is another key part of an aim statement, to publicly state what it is you want, how you want to improve, how much, and by when. So here's that by when over the next 12 months. Another important part of an aim statement that can be very helpful is to describe, really it's their working theory of what are the things they think they need to change in order to decrease their rehospitalization for patients with heart failure in the next 12 months. And in this top aim statement, we have This is really their working theory. This is where they'll do tests of change. They'll develop a protocol for congestive heart failure. They will work on staff education. They think the use of a zone tool for congestive heart failure and medication management are key areas that they need to change how they're doing that kind of work now in order to get a different result or decrease their acute care hospitalizations. They also have some other things in here which is great, and that is this top number is their outcome measure, decreasing rehospitalization rates. They also have some process measures, things that they'll track along the way to see if the changes that they're making are making a difference. And those areas are around med management, using the OASIS data. And also they might have a process measure around improved management of disease processes by patients and caregivers. In our next call, we'll talk more about measurement strategies and the importance of having outcome and process measures, but this is a great example to highlight those as well. In the second AIM statement, again, just to point out, this group wants to improve their ER visits and rehospitalization rates. They want to do it, they want to improve in the next 12 months, improve ER visits by 50% and rehospitalization rates by 25%. And here in the middle, it talks about, again, what's their working theory of what they think they need to change. Providing the client caregiver with their own personal emergency plan in the first week, necessary phone numbers, who to call, etc. So two really great examples of AIM statements. For those of you who haven't written your AIM statement, really, even if you're not quite ready for an improvement project, to go through the practice of writing one, really encourage you to do that. All right, so let's move to our topic for today, which is really PDSA cycles for learning. And just start out with a little bit of humor here. So here we have Hagar visiting the doctor, and here's the doctor. Okay, they need to get a little bit of information, start some assessment, maybe do some planning. Here in this version, we get a little bit more context. Something Hagar must be in for something around back pains. Great, so we kind of know what's going on, right? Well, in this next slide, we see that right before that doctor's eyes, there's something that he could act on right away. And we do think it's important to set up your improvement project well, to do some assessment and planning, but we also know that getting to action so that you can learn about your system, getting to action pretty quickly is important. And so this is just a little bit of humor to drive that point home, that there are things right before our eyes that we know are not going well and need improvement, and we can start on those right away, although we want to do it in a methodical fashion so that we learn. And that's pretty much the point of our call today. And so with this, I'm going to hand the call over to Jane Taylor, and she's going to walk us through PDSA and how you really learn from doing these iterative tests of change. So
Thank
Jane.
you, Corey. Thank you. And you've got the ball, so could I have the next slide?
Yes.
Or you can hand it over to me, either one. Oh, great, thanks.
There you have
I've got the ball. Great. So what I want to talk today about is the model for improvement. And you know, because you wrote your AIM statements, that the first question in the model for improvement is, what are we trying to accomplish? And we like to use SMART aims for that. And then the second question in a SMART aim just says, by when, how much, for whom, and gives some concrete goals. The second question in the model for improvement is, how will we know that a change is an improvement? And as Corey said, that's where measurement comes in, because measures answer the question, how am I doing? Did the change I make really work? And then the third question in the model for improvement is, what are the changes that we can make that will result in improvement? And can I take those changes and make a prediction about them or a plan, try them out, preferably on a small scale, study what happened compared to my prediction, and decide what I want to do next, so that I let one small test of change inform the next action item or next test of change. So why do we use the model for improvement when we talk about quality improvement? Well, the best reason I can think of is that it's useful. And it's very simple, just those 3 questions. What are we trying to accomplish? How will we know? And what should we do? And those 3 questions are incredibly robust. And because of their robustness, they really help us get some shape or get our arms around some of the complexity of trying to do improvement. And what we've seen is that you could use the model for improvement at any level in an organization or in any group, from your governance board asking those 3 questions all the way down to staff who are trying to figure out, what do we need to do today? What is it we need to accomplish? How will we know if we get it done? What are the changes we need to do to make that happen? So these 3 questions are very robust, and they encourage teamwork because we can get staff involved in the small tests of change. And by getting staff involved, I can foster teamwork. And the way that I do that is I encourage staff by asking them, do you have a hunch of something that we could do that would make this better? Do you have a hunch of one thing that we could do that would help reduce rehospitalizations or ED visits for our patients? And then could we try that? And could we try it on a small scale, say, with the very next patient? So by asking staff, based on their experience and their know-how and their evidence base of knowledge, what ideas they have to bring about improvement, I can engage them in making improvement. So it emphasizes and encourages learning from data and not making judgments from data. So we collect data to tell us, how are we doing? Is this really working or not? We don't collect data to decide if we're good or if we're bad. So this provides us a way to create some empowerment in your agencies. And the vehicle that we test these ideas out with, that we test changes with, is really the scientific method made simple. So you know, in the scientific method, if you think back to 9th grade science class, you have a hypothesis. Well, we have a plan. And we have a prediction that's part of our hypothesis. Then we run our experiment, and we study the results compared to our hypothesis, and then we decide to accept or reject our hypothesis. Now we're going to make that more simple, and we're going to say we're going to have a plan. I have a hunch that if I do a super job on medication reconciliation and talking with the physician about duplicate or meds that are interacting in negative ways with the patient, that I could reduce or prevent an avoidable rehospitalization. So I'm going to try that out on a small scale. I'm going to do it on my next admission. And I'm going to actually call the physician or call the office and talk to them about what I'm seeing in my medication reconciliation. I'm going to study whether that was a good idea or not. Maybe I made a prediction that I would be able to talk with the physician directly, and when I do my study, I found out no, but I was able to talk to her nurse. And so based on that, what do I want to do next? And then I might try it again. So here's an example in using a personal health record. So I have a hunch or a theory, a prediction that I'm going to try out. And my prediction is that if I use a personal health record, I can increase real-time communication among clinicians, and I could reduce excessive admissions. And so what do I know about this? My agency has a 30% acute care hospitalization admission rate. And so I'm going to take a page out of Eric Coleman's Care Transitions model, and I'm going to try using this personal health record. Now, if I just try this with one patient, do you think I'm going to see a big enough reduction to move that 30%? No. But what I am going to learn is what is the utility about using the personal health record, what makes it easy, what makes it difficult, how long does it take. I'm going to learn a lot of things. So I want to think of all the questions I have before I start my PDSA cycle, and I'm going to start testing it. So maybe I'm first going to mock up the form over a series of a few staff meetings, and I'm going to include the home health aides as I mock up that form. And so my actual first test might be to take it to staff and do a little role play and get their reaction to it. So I could do a simulation for the first time. And I could make some revisions because maybe this personal health record is too complicated or not health literate enough. So then my second PDSA cycle is I'm going to simplify this form. I'm going to bring it back to staff and ask them to role play again, and maybe this time they role play a patient who has a very highly engaged family member, and maybe they do a second role play with a patient that doesn't have an engaged family member. So I want to test it under a variety of conditions, simulation first with staff, and then I'm going to decide to take that out into the field. And I'm going to try it with the next two patients. And who's going to do it? The RN and the physical therapist. One is going to do one patient, the physical therapist will do the other on an admission. And the physical therapist, though, requested an additional amount of time, and the RN felt that it actually took too long to use. That was what they learned when they did the test on a regular basis. So based on those findings, the RN felt it took too long, and the physical therapist thought maybe she needed a little bit more time. I'm going to get the two of them together and have them revise the form and try it on 2 more patients. Now the PT is happy with the form. It didn't take longer, and the RN was actually able to reduce the time she took to fill out the form by 50%. So you can see that we have not implemented this yet. We have not designed it for our electronic medical record yet. We're still testing this on paper in the field, paper before vapor, to see if it works. Now, just because it worked with this RN and this physical therapist and these 2 particular patients doesn't mean it's going to work on all patients. So on my next test, I might try and test this on all the patients I'm going to see this week, because I know I'm going to see patients that are not as facile with English. I know I'm going to see a patient that has some cognitive deficits. I know I'm going to see a patient who is highly health literate. So I know in a week I'm going to see a variety of patients. And if I run this test for a week, I'll get a lot of useful information about how robust is this form. Then, well, can other people use it? Maybe a home health aide. We want to get a home health aide using it. And we want to get some other PTs to use it to see if it works for others, because just because it works for me doesn't mean it's going to work for everyone else. And I want to learn that before I go to implementation. And I think I would just like to pause here and say that the biggest error I see young improvers making, or people new to improvement science, is that they go to implementation too soon. They're tempted to go to implementation maybe after their first test, after the first time they tried it in the field, or maybe after the second time they tried it in the field. And they'll say, okay, it worked on 2 patients, let's implement it. Or what I'm seeing more now is because of electronic health record, a lot of people want to put things in the health record before they test them, because that gives them the reminder and a place to record what they're doing. And then you're stuck with whatever you put in the health record, because it's so hard. Sometimes they're so rigid, and it's so hard to make changes once you've put something in the record. So you can tell here we tested it more than 8 times before we went to implementation. Now what we did in our 7th PDSA cycle is one of our staff said, you know what, I think I could do it even faster if I had a script to follow. So we wrote a script, and we found that, yes, that could cut down our time, and not only that, it increased understanding with our patients. And then finally, we thought we should engage a primary care office and test the setup of this form. So we took this personal health record to an office visit. We had a patient take it to an office visit, and the PCP loved it and even suggested some changes that would make the form helpful for the primary care physician as well. So now we're ready to think about implementation. And implementation actually requires thinking about training staff, orienting staff, writing some procedures, making things permanent by putting them in the electronic medical record. So there's quite a bit of work once you go to implementation. But this is what the Plan, Do, Study, Act cycle looks like. And you can see that when you start out, you should have some questions. How long is it going to take us to do this? Will it work on all kinds of patients? Can different members of the care team use it? And then we're going to carry out our first test. And we actually say, who's going to do it? What is the nurse's name? Yolanda. Yolanda is going to try it. When is she going to try it? Next Tuesday. On the first patient that she sees. Where is she going to, how's she going to write down what she learns? So all of these things are thought about before you even start your PDSA cycle. And what is my prediction? What do I think is going to happen? Do I think this is going to take 2 hours to do, or do I think this is going to take 10 minutes? Do I think the patient is going to understand it, or it will require more explanation? So I make predictions. Then I just do my experiment. I carry out my plan, and I document what happened. But I'm not done yet. I have to compare what happened. I thought it would take half an hour to fill out. It took 45 minutes. I'm not going to be able to do this because 45 minutes is too long. So now, my prediction was off. So what am I going to do to reduce the amount of time it takes to complete this this personal health record? So I start off very small scale, 1 patient, 1 day. Then I'm going to do some follow-up tests after I revise the personal health record. Then I'm going to test it on a broader scale. I'm going to test it on all my patients this week, and so is the physical therapist. And not only that, but we're going to have home health aides tested. So we're going to have much more data before we go to implementation of the change. And our prediction was the change would help reduce readmission. So now we want to see how often are we getting the health record, personal health record completed. Is it useful for patients? Is it useful for staff? And later, is it actually helping us move our DOT, which is reducing those rehospitalizations or acute care hospitalizations? Now, one of the things is that you can do multiple cycles. So we just talked about testing one thing, that was the personal health record. But maybe our overall aim is to make sure that patients are safe and stable at home. So maybe we want to do some tests of change around medication management. And then at the same time, we may have another care team who says, all right, we're going to work on self-management support. We're going to do some motivational interviewing with our patients. We're going to have patients write goals. We're going to try lots of things around self-management. And then maybe you have another group of staff who are very interested in making sure that you're doing evidence-based care or timely connection to PCP. So if you want to accelerate your rate of improvement, you simply work in multiple areas concurrently. Now, the limiting factor doing this is how much ambiguity your staff can handle, how much change they can balance at one time, and you yourself leading the improvement effort, how much can you manage? Because sometimes these PDSA cycles, imagine, you may have 10 or 12 PDSA cycles going at once, and so it's a lot to juggle. So why are we so big about testing and using PDSA cycles in improvement work? One reason is rigor. You know, we want to make sure that there's a method to our madness and that we can get results. And not only that, but that at the end you could tell the story of how you got the results you got. Because if one of you out there managed to really hit a home run reducing readmissions and you were able to cut those rehospitalizations from 30% to 15%, doesn't the rest of the nation want to hear about that? And wouldn't we like to know, what did you do? What was the sequence? How did you do this? So that's one of the reasons that we want you to be rigorous in your PDSA hygiene, I call it. But when you're testing, you also want to increase the degree of belief that the change that you make is really going to bring about improvement. Because if it isn't, change is too costly to do. So you also might want to decide which of these changes that we're considering has the most merit, the most weight, or is going to move us in the direction of goodness or what we're trying to accomplish. Which one has the most leverage? And then we want to evaluate, well, if we're making this change, you know, we're going to go to all this trouble to build this personal health record. Is it going to really make much of a difference or not? is the juice worth the squeeze, is how I say it in my vernacular. So we have to decide, how are we going to adapt to these changes? Because maybe I hear about a change in Pottsville, Pennsylvania, and I know it works in Pottsville, Pennsylvania, but I'm really wondering how is it going to work in Redwood, California? So and agencies are all different too. So how am I going to adapt the change based on the unique characteristics and staff strengths of my agency? So I want to evaluate also, is it going to cost me a lot of money to do this? What is my business case for it? And I want to give my staff a chance to experience creating the change as we make the change, so that they're supportive even before we get to implementation. And I have a colleague, Bob Lloyd at IHI, who says, be careful when you use any acronyms, because PDSA, if you happen to be in England, it stands for the People's Dispensary for Sick Animals. So if you talk about how many PDSAs did you do, people are going to wonder why you're talking about the People's Dispensary for Sick Animals. So one way to think about Plan, Do, Study, Act cycle is, this is an example from surgery, but it's illustrative. The plan can be simply, this was a case where we wanted to test replacing clippers, using clippers instead of razors, because razors abrade the skin and bacteria can get in and patients can get an infection. So our plan, ask one doctor to use clippers instead of a razor with just one patient. Now, if this works, are we going to go straight to implementation? No, we haven't learned enough. That might be crazy because we know our surgeons are all different. So we're going to use those clippers. Dr. M used those clippers on 2 patients, and he was happy. And he actually said to staff, don't give me any more razors. Don't put them on my carts anymore. So the study, it turned out that the staff really wasn't able to do it because they didn't have enough clippers. So what are they going to do? They ordered clippers, but they decided that they would continue testing with 5 other surgeons before they went to implementation. So I just want to pause right now and find out from all of you what questions you might have, what this provokes among you. So if we could open the lines, I'd love to hear from you.
Thank you, Jane. We have a first question from Shauna, who says, hello, this is great information. This is a very basic question, but she would like your thoughts. When introducing this to her staff, what is a good approach that you have found to create buy-in amongst staff?
Oh, that's such a great question. Well, I always tune into that radio station, WIFM, and that's what's in it for me. So I try and think about what's in it for staff, and then I try and communicate how this is going to help them, how this is going to help their patients, and how I'm not going to implement anything without having them try it first and give me feedback.
Great.
And I like to keep my language, I would just say one other thing, keep language simple. Don't make it complicated, and speak in a way that staff like to, that staff are accustomed to speaking with each other.
Excellent. Our next question is a more functional question, and one that I can answer for this one. This is from Kay, who says, I'm sorry, but I'm having difficulties locating where to post the homework. Can you help me? And I can answer that by telling Kay to just contact us at hhqi@wvmi.org, and we can send you a direct link to our discussion forum on the Home Health Quality Improvement website and instructions on how to access so that you can post your homework. That's all the questions we have right now in the hopper, Jane, but we'll continue compiling those from our participants. And if folks have more questions, please keep sending them to hhqi@wvmi.org, and we should have an opportunity for more feedback a little later in the presentation. Jane?
Thank you. Thank you. So here's some hints when you're getting ready to do Plan, Do, Study, Act cycles. Always think a couple of tests ahead, just like a chess game. If this works with 2 patients who are pretty highly health literate, would this personal health record work with patients that don't speak English? So what might I test next? Or if this way of doing medication reconciliation works, my first test, what's going to be my second test and maybe my third test? Now, the most important piece of advice I have today is scale down the size of your tests and decrease the time it takes to run a test. So I was teaching yesterday a group of improvement advisors, and someone said, well, if I only do a test a month, it's going to take me a year to get 12 data points to even understand what's happening. And I said, well, right, and if you did a test a week, you would get 4 data points a month. And if you did a test a day, you would get 20 data points in a month. So the more tests that you can do on the smaller size, just one patient, one staff, one day, one admission, one follow-up visit, one transfer of care, if you can scale, if you can just limit your tests to as small as you can think of and still learn, you will accelerate, oddly, you will accelerate your rate of learning. So make your tests small. And if staff come to you and they say, well, we want to try this for a month, ask staff this question. If we did it for 2 weeks, if we did it for a month, would we learn anything more than if we did it for 2 weeks? If we did it for 1 week, would we learn anything more than we would in 2 weeks? And so if their answer is no, then 1 week is good. If their answer is, well, yes, we would, and here's why, then you might consider running it for 2 weeks. But the rule of thumb is take the initial size that people want to test, cut it in half, and cut it in half again. So if they want to do 10 patients, cut that in half to 5, and then try doing it with 3 patients. Don't worry about getting buy-in or consensus before you start the test from every single person, because you know what? If it's a good idea and it's not going to hurt a patient, let's just try it. And if you have a good idea, let's say Bethany has a good idea and Corey has a good idea, maybe I'll test both of those ideas because I'm only going to test it on 1 patient. So I can actually test a lot of staff's ideas, and I don't have to get buy-in. But when we get ready to implement, I do need some buy-in, and I do have to communicate around that. So I might need some temporary supports to make my change feasible during the first test, and I might need to be innovative about that. So sometimes we've done some tests where we give patients a cell phone, and they can call their primary care physician directly. You know, their situation is so, their concerns are so important that maybe they just need to get right through. Well, office practices say, well, we can't get a cell phone. We can't, you know, they have 1,000 reasons why they can't do it. Well, maybe we could buy a temporary disposable cell phone and try it for a week. Or maybe we could try it for 1 day with a temporary disposable cell phone. So you've got to be innovative about how to make your tests work. And don't forget, you can simulate your tests like we did with our own staff role-playing, even before we go out to the field. So here's a cartoon I got from Sandy Murray, and it says 2 cavemen, and 1 caveman is recording data, and the other one has 2 fish in his hands, and he says, negative results on the fish. Let's try rubbing 2 sticks together. Now finally, I'm going to say that I love this chart because this helps me decide how big of a test of change to make. So what I do is I say, are staff resistant to this idea, indifferent, or are they ready for it? Maybe are patients resistant, indifferent, or ready? And is my degree of belief that this change will lead to improvement low, or is it high? And what about the cost of failure? If I run this test and it doesn't work, is my cost of failure large or is it small? Now that could be financial, but it could also be the willingness of staff to test again. So it could be around will. So if staff is resistant, the cost of failure is large, and I'm not sure this is such a great idea, then I want to make a very small test, a very small scale test. But let's say that I have a high degree of belief that this change is going to work. The cost of failure is small, and staff are indifferent. Some want to do it and some don't. I can do a larger scale test. But you'll notice there's only one time when I can go straight to implementation, and that is if staff are ready. I know that this is an evidence-based change. It's I have a high degree of belief that it'll lead to improvement. and the cost of failure is large. So what I like to point out is there's only one place where those conditions happen, and that's right here. And I've been doing improvement work since 1982, and I've only seen this condition once, and it was in Canada actually. So if you look at this chart, you notice that almost all the cells are very small scale tests. But one thing that you can do with staff when you're working with staff is print this up and lay it down in front of them on the table and say, let's see, are we resistant, indifferent, or ready? What is our degree of belief, and what about the cost of failure? And what does that suggest about the size of test that we should make? So when you get ready to go to implementation, you've tried your personal health record, you're sure it's a great idea. You don't need really to think about small test of change anymore because you're ready to make this part of your routine way you do things. So what are the support processes that will make that work? And you're really trying to figure out about making it a permanent part of your work, a permanent part of your change. And so we're moving from small tests of change to larger tests of change. And some of the things to think about are training, orientation, policies and procedures, putting it in the electronic medical record, and then monitoring it to make sure that you hold your gains. Now, when you get ready to go to implementation, sometimes, because now I've just gone from my willing to test nurse and nurse cooperative to all my staff. And so sometimes you will meet more resistance, so you've got to think about a communication plan and messaging. You might run into some problems that you didn't during testing, and you really need to keep some data to see if your process is reliable. So an example might be all patients admitted to the certified service beginning March 1st will be given a personal health record on admission and oriented on how to use that personal health record. So as I get ready to implement that, these are some of the things that I need to think about. Implementation is hard work, by the way. So I've got to think about, I mentioned this already, that radio station, what's in it for me. I've mentioned policy and procedure and training, IT. Is there any equipment that we'll need? Anything that has to change in the job description? And then here's a biggie. Who is going to be responsible for this change? Designating somebody to make them responsible. So we've got some polling results. So let me stop and let's go to the polling results. And I would like to give the ball back to Corey. So maybe, Corey, you could even, while I give you the ball, go over some of these polling results.
Thanks, Jane. And we will also stop for questions before we go to Sally Sobolewski, who's going to provide us with an example. So if you have any questions, send those in, and we'll go to those in a minute. So the question is, can you think of a change that you might do on your next readmission or next admission? And most people picked answer C, I want to ask my staff first. Actually, that's not true. Sorry, I haven't read polls before. Most people said yes, so that's a great answer. People are able to think of tests that they might want to change. There's some folks who aren't quite sure what tests they might do, and a number of people did want to ask their staff first, so they would go to their staff first. So great. Thanks for answering our poll. Once I could read it here. And Shannon, what questions do we have in the queue?
We have a question here from Heather who asks, how do you recommend communicating this to staff? Through a meeting, face-to-face, emails? What would be your recommendation?
Jane,
if I were,
go ahead, Jane.
I was going to say, if I'm communicating that I'm using the model for improvement, I would probably do it face-to-face. If I'm doing small tests of change, I want to do, if I'm doing a particular PDSA cycle, I'll tee that up with a nurse face-to-face or on the phone. It depends on my relationship with her, or staff, I should say. And if I'm, so I don't want to just email staff that maybe I don't have who don't know what this is about and aren't prepared to test something or even understand what it is, I don't want to communicate with them in email. But if I'm showing results and I'm showing data over time that shows these great outcomes related to changes that we've done, I might do it in a note in the email so that everybody knows what we're doing. And I might let everybody know in a broad email that we're going to be trying some things around the personal health record, and we're going to start with a couple of tests of change that Sally is going to make and Yolanda are going to make. But I wouldn't, I would use broad email for communicating, not requesting. Corey, what about you?
Yeah, the only thing I would add, Jane, is in the last call we talked about leadership setup for change. If you're embarking on some fairly significant change, then I think it's good to communicate with staff what the change is, what your goals are, and then how you're going to go about it. And how you're going to go about it might be as simple as, we're going to have a few staff test some things, and we'll let you know about it as we go along. You know, these are the people that are going to be trying things. We'll involve you as we go along, those kinds of things. So I might frame the change in a big way across the agency and then dive into the details so that people know what's going on.
Right. Thank you.
Shannon, any other questions?
We have a couple others, but they are more global in nature and might be better suited for our final Q&A break if time allows at the end of the presentation. So I think we can move forward now if you like.
All right. Great. We have some hold music, and once we take care of that, then Sally, who is on the phone with us, we'll walk through her example. But Bethany, we'll wait till you manage that hold music.
I'm sorry, I was trying to find Sally's line.
United Way Agency
Okay.
care services with integrity, experience.
Just so folks know, Sally had some computer problems this morning, and she's on the phone only, and Bethany is finding her. How are we doing, Bethany?
I got her on a different line.
Sally, are you there?
Not well.
I'm not sure we're going to be able to find her now. Corey, is there any way you can take over Sally's slot?
I can walk through it, and so yeah, why don't I do that, and then we'll tee up for questions that people have to wrap this up, and we'll talk about our recommended homework after this call. And so this is a set of PDSAs that Sally and her staff from Visiting Nurse Service of New York performed around improving medication management. They had a goal to reduce hospitalization rates. And Sally is director of their quality improvement department of that very large agency. They've worked many quality improvement projects and have done a lot of partnering with their partnering hospitals around these PDSAs. So let's just walk through it, and let's take a look at how they set up their project and the kinds of PDSAs that they ran. So we'll go from the bottom up. So the first set of tests or PDSAs that they ran was that 3 nurses participating in the project, let's see, I'm going to have to read these. Let's see here. So the problem was that they were not getting information so that they could start their medication reconciliation process. So that was a problem in the home. They did some study of this process, and they showed that 40% of the patients for a week did not have the medication list. And this was really important information for Sally and her staff to be able to take back to their hospital partners, because previous to this, the hospital was saying, why are these people getting readmitted? We're giving you all the information. And this was great data to take back and say, hey, we do have this information. We're not getting on 40% of these patients, we did not get the medication list. So that kind of was a way to get the hospital partner to the table and start working with them more. Their next set of tests, so that first set was really some studying of the situation. The next set of tests starts to get into some action, setting up a meeting with the home care liaisons, and setting up a test to have the liaisons talk to patients about having the list ready for the nurse on the first home visit. And so the change was, can we pre-activate patients to bring their list to the table because, or to the home visit when the nurse was there, so that it would be there more reliably. And what they found is in this test, for the next week, at 75% of those visits, the medication list was there. So definitely an improvement and learning from that. The next set of tests was for the liaison to work with the hospital discharge staff to really improve the process of the patients having the list. The theory being if all the patients had the list and they could pre-activate patients to make sure the list was there, not thrown in the trash can or not hidden in a bunch of other piles of paper that couldn't be found, but actually have it there when the nurse came, that then the nurse would have the medication information to be able to do the reconciliation. In this set of tests, with the hospital staff joining in, 100% of the patients had the list of medications when the nurse was came to the first home visit. The next, and there were a number of PDSAs, as Jane described, small tests of change in all of these buckets. So these are the big buckets. And in the final bucket, test 4, they looked at what are the other gaps. So they found a process way through testing to get the medication list to the patients. They were successful at pre-activating patients to have that list there on the table when the nurse was there. And so they wanted the next chunk of information that they looked at were other gaps in people getting their discharge medication lists. And so that, you know, if Sally if we could find her line, she could tell you what those other gaps were and the PDSAs that they did around those. And so through a rigorous and systematic process of using PDSA, having an aim statement, a theory of improved medication management, some measures, and then systematically working through these, the Visiting Nurse Service of New York was able to improve their medication management process. All right, so at this point, I think that's probably the best I can do at describing the story that Sally was bringing to us. And
other immunizations that can protect.
Shannon, let's have other questions.
The single best way to prevent.
Okay, next question we have in the queue comes from Julie, who asks, at what point in the PDSA cycle do you include this information in a chart or permanent record?
I'll take a stab at that, and then Jane, please jump in. Most PDSAs, I'm going to go out on a limb here and say most PDSAs that healthcare people are doing are trying to improve care processes to existing best practices. So as an example, if I'm a nurse and I'm doing home visits and running PDSAs on improving medication management or patient engagement and using TeachBack, I'm not doing an experiment that's something not proven. I'm really trying to improve towards best practice. And so I think I would document the result from a clinical perspective in the record. So if I'm doing TeachBack and I ask the patient, can you describe to me, you know, what we went over in terms of the medications you should be taking right now, and the patient could teach back to me 70% of the medications, I would just document that in the chart that the patient was able to say that they were supposed to be taking these 3 medications, but they missed these 2. And so I would just document in the chart the basic facts, but not really the PDSA. The documentation of the PDSA of trying something different is a documentation for the team back at the home health agency to study. Jane, would you add anything to that?
I'm sorry, Corey. Jane actually had to log off a little bit early because of a schedule conflict, so she's no longer on the phone line. But I can move to the next question if you would like.
Sounds good.
All right. This person writes and says that she has staff that are always resistant with change, yet are influential to other staff. Should I involve this person in the testing phase?
Well, it's a really great question. And one of the things that Jane said that I think is that you can really leverage is that there's a way to test many different ideas. And so one of the things that setting up an improvement project and then running tests of change on is that you resolve some conflicts through testing and through data. And so I have seen efforts that are very successful that start with the willing, so people who are willing to test, are excited about it, want to try it. And I've also seen efforts where including the people that are resistant way up front and getting them involved in the testing is also a really good strategy. So in some ways it's a judgment call, but using tests of change in many ways is a change management strategy. If it were up to me, most of the time I would probably involve, if someone were resistant and influential, I would probably involve them up front if possible, because then you have the opportunity to engage their energy. Sounds like they have a lot of energy. You want to put it towards your change effort. It gives them a voice. You have the opportunity to hear what they have to say, and then through testing and using rigorous quality improvement science methods, you can start to move their thinking to be involved with the project and positive with the project, or in a sense you can start to debunk their resistance. All right, Shannon, what's next?
We have a question from John who asks, what advice do you have for a director of nursing in a small agency that may be responsible for process improvement along with everything else as far as fitting this improvement process into their busy schedules?
Another great question. And what I would advise is finding some time to think about what you really want to improve, what's going to be of strategic importance to your organization. Don't take on projects that aren't going to be important because you won't sustain them. What are the top 1 or 2 things? Or maybe just one thing if you're a really small agency. Take some time to set it up well, so think through your aim, think through what measures, get measures that are good enough. They don't have to be perfect, but good enough, and we'll talk about those on the next call, that you can guide your improvement. And then with the staff that are available and willing, just start trying tests of change. If you can do 1 or 2 a week, and that's all you can do, just keep at it. Be very persistent, but find efficient ways to study those PDSAs and learn from them and set up your next PDSAs. And so in some ways the message is get set up well, and then just keep going and become good learners and use the little bit of time you have to good purpose. And then lastly, again, make sure that it's of strategic importance to your agency so that you're using your time well. Great questions. Do we have more, Shannon?
Yes. Next one comes from Marilyn, who asks, what is the improvement guide referenced in the slides?
The improvement guide is a book, and they just came out with the 2nd edition, I think, last year. There's a group of folks called the Associates for Process Improvement. They're a group of people that studied with Deming, who is really the grandfather of process improvement. He studied many, many different industries, took a really systematic approach, and really articulated and put together what kind of process do companies use that actually improve. So lots of companies, all companies, churn through change, do a lot of activity to change, but what are the things that in the end the change actually creates an improvement, that it actually creates a better future state? And so the Improvement Guide is a book written by the Associates of Process Improvement. It's a summary of Deming's writings, and they incorporated his work into the Model for Improvement. So it's a really, really great reference. There's lots of stuff on IHI.org that's free and a reference, but if you really want to get into this, it's a good read. It's quite a useful guide. And we can send that reference out after the call.
And I think we'll wrap up the interactive portion of today's live webinar with a comment for you, Corey. And this comes from Kayla, who says, I don't have a question, but just wanted to thank you so much for the presentation today. It's much easier to understand by listening to you and Jane rather than reading on the subject. Thank you so much.
Great, thank you. And we do have some homework. So I'll just move to there. We recommend that with your team you write a PDSA, and then maybe by the next call just run 2 tests of change. So maybe you don't have time to set up a whole thing and you're not sure what you're going to do. Can you run a PDSA? Can you go through those steps that Jane described? Can you run 2 of them and then learn, reflect on what you learned from running those tests, both about the process, for example, medication management, but also what you learn about the process of PDSA. Post it to the website, and we'll pick up on some of those on our next call. With that, Shannon, I think, are you going to wrap us up today?
Yes, I will wrap it up, and thank you so much, Corey, and thank you, Jane, for the excellent presentations today here in our second episode of Pave Your Path to Quality Improvement. Our next upcoming calls live will be April 16th at noon Eastern, and the topic will be Learning Toward Improvement. We still have several open slots to register for this, so please visit homehealthquality.org if you haven't yet signed up for our next live session on April 16th. Then we wrap up the 4-part series on May 21st at noon Eastern by talking about improvement science and helpful techniques. So we invite you to visit homehealthquality.org for a copy of the handouts or slides from today's presentation, and we will also upload a recording of this presentation to the site soon. As you log off from today's webinar, you will be directly linked to an assessment so you can provide us feedback on today's webinar presentation, and thank you in advance for providing this feedback. And most of all, thank you for joining us today. We look forward to talking with you next month on Episode 3 of Pave Your Path. Have a great day.